Good day. We have the pleasure to have with us today Dr. Adil Adatia, specialist in allergy and immunology, assistant professor at Faculty of Medicine of University of Alberta. He has also collaborated over 20 scientific publications and is also a member of Chain. Thank you for being there, Adil.
Thank you very much for having me. It's a real pleasure.
So today you'll be talking to us about new treatments that are already available and the ones that are coming to market in a year or a year and a half, 2 years from now. Is that it?
That's right.
Perfect. So the floor is yours, my friend.
Excellent. Thanks again for having me for this discussion. I'm always eager to talk with patients about hereditary angioedema and the exciting treatments that we have coming that are here already and are coming soon. So I always like to begin with an overview of hereditary angioedema, since whenever I give a talk, sometimes there can be patients who are even newly diagnosed or recently diagnosed. And so we'll go over that, which might be a review for some of you. And then we'll talk about exactly what is happening in the blood that triggers the swelling and where exactly the medicines that we have available interact in that pathway to treat or prevent swelling. And then we'll talk a little bit about advances in things like diagnostics with genetic testing and in delivery of care to patients with HAE. So to start off, HAE, or hereditary angioedema, is more completely called hereditary angioedema with C1 inhibitor deficiency. And this is a genetic condition, and it affects around 1 in 50,000 individuals. So we would consider it a rare disease. And generally, we consider there to be two types. There's type 1 and type 2, although the experience of the patient, the symptoms of swelling, are identical between the two groups. The disease occurs when patients are born with a change in their DNA in a gene called SERPING1. And SERPING1 encodes a protein called C1 inhibitor. And as a result, patients with hereditary angioedema don't make effective C1 inhibitor protein. And the absence of that effective protein eventually leads to swelling. And we'll talk about that in more detail shortly. Around 75% will inherit this condition from a parent, so it is very common for there to be a family history in a newly diagnosed patient, but it's not required, and certainly there can be new changes in DNA every time someone is born, and around 25% of newly diagnosed individuals will actually not have a family history, and the changes occurred for the first time in them. So many of you will have already experienced angioedema and know very much what those symptoms entail. But I still like to show pictures because certain people have swelling in some areas and not others. And if there are family members or caregivers watching, I think it's helpful for them to also see what the swelling can look like. So you can see here a picture of a woman in the top left-hand corner. You can see her normal face, and as we go from panel B, C, and D, you can see the evolution of swelling in her face, getting worse over time. And so this type of swelling is what we call angioedema, and this is the type of swelling that patients with this condition can experience. It can also affect other areas. So this is a picture of someone's airway. And so if you can imagine having a camera in your throat looking downwards at the airway, the airway on the left is closer to normal. And then you can see that it's now almost entirely obstructed with swelling on the right. And this is the type of swelling we worry most about, because if the airway is obstructed, then it could be life-threatening. Some individuals get a rash with their hereditary angioedema, and this is a picture of that rash. You may be able to see that there's this red lacy rash that's flat against the skin. It has a medical name, and it's erythema marginatum. And some individuals find that they get this rash right before they're about to get episodes of swelling, but that's not a universal finding. And here is an example of tongue swelling. And in individuals who are not familiar with this, they may think that this patient is just sticking out her tongue, when in fact her tongue is so large she can't put it back in her mouth. And so I think it's easy to appreciate that there is the possibility of significant disability from hereditary angioedema. And that's why we take treatment very seriously, and we want to make sure that all patients are well treated. So everyone's hereditary angioedema symptoms can begin at different times, but in the majority of individuals, it does start in childhood. And we will be talking a little bit about treatments for children today. And I think that's very important because the majority of patients have their first episode when they're quite young. And that means that they're going to have this condition for essentially the entirety of their lives. And I think it's very important that we consider treatment both for children and for adults. And historically, it was thought that children were not very much affected, or it was rare for them to have attacks. And we now know that that's not true. And they do have debilitating attacks, and that can affect things like their development and their social life. And it's something that we want to prioritize. This is a breakdown of where patients tend to get attacks. Each patient, again, is different, but most commonly are the extremities like the hands and feet. But the face is also quite common. And not really well shown on this graph is also abdominal attacks, which are also quite common and are extremely painful. So why do you get swelling with hereditary angioedema? What is happening in the body? So we're going to start off here. So this is an example of swelling. There's angioedema of the lips in this patient. So how did we get here? There's this molecule called bradykinin. It's a very small molecule, and it binds to the inside of the blood vessel. And when it does that, it makes the blood vessel become a little bit leaky. And the fluid in the bloodstream that comprises blood can then leak out of that blood vessel in the area that has become leaky. Like, let's say it's a hand, for instance, or in this patient, it's the lips. That fluid then goes into the tissues, and that creates the swelling that patients then experience. And the stretching of those tissues that's abnormal can contribute to the burning, tingling, and significant pain if it goes on long enough in those patients. So where does this bradykinin come from? Well, it comes from this molecule called kininogen. So bradykinin makes up a tiny piece of that molecule. And you can see here that the bradykinin triangle is a little piece of that pie. And you need these scissors that cut that bradykinin piece out that will then cause the swelling. And those scissors are called plasma kallikrein. So that is an enzyme that is in the bloodstream, and its role is to make bradykinin by cutting up the kininogen. And the scissors, you can think of them as being a form of safety scissors, that they're kind of closed and locked in place. And that therefore they have to be activated. And that comes from a protein called factor 12, which is also part of the clotting pathway. And when factor 12 is activated, it removes the safety device from the scissors, and the kallikrein can then cut up the kininogen, make the bradykinin, and we end up with swelling. So where does the C1 inhibitor come into this? So the C1 inhibitor is the brake on this process. It helps prevent the activity of plasma kallikrein so that you don't get too much activity of these scissors, so you don't get too much of this bradykinin that will cause abnormal swelling. But if you have hereditary angioedema, you don't have enough of this C1 inhibitor. So that brake on the process is missing. And that's why this process occurs too much, and you end up with recurrent episodes of the angioedema. So in terms of treatment, When a patient is experiencing attacks, we want them to use treatment, and all attacks should be considered for treatment. And we can leave it up to the patient in some circumstances that if it's a very minor episode of a small area of swelling on the hand, they may choose not to treat it, but they certainly should feel comfortable doing so. And then there are some attacks that we really insist they must treat. And these are attacks of the lower face, for instance, and the throat, because these can be very serious. And abdominal attacks, which can become very debilitating, we also very much encourage treatment. And so we want patients to always have at least 2 doses of on-demand treatment available to them to treat attacks. And in Canada, we are lucky that we have, for most patients, good access to the modern on-demand treatments. And one of them is called Firazyr or icatibant. That's shown on the left here. And that's given an injection into the fatty tissue, or what we call a subcutaneous injection. And then we have Berinert, which is an IV infusion, and that is the C1 inhibitor protein itself that has been collected from blood donors. So when you're using these on-demand attacks, what's happening is you are giving back the break. And so if you infuse Berinert at the time of swelling, like in this patient when the lips are swollen, you replace the break that is not present with the Berinert, and that slows down that process, and then the body will reabsorb the fluid that has already moved into the tissues. Alternatively, you can block the bradykinin, and that is what the drug Firazyr or icatibant does. Many of you may have heard from your doctors that when you're treating an attack, we want you to treat them as early as possible. And the reason for that is because it dramatically improves your ability to settle that attack down quickly. In this picture, you can see different curves representing different attack trajectories. So on the y-axis, we have the severity of the swelling, and we have time on the x-axis. And the blue curve represents what would happen if there was no treatment. And you can see over time, the swelling builds up and it reaches a high level of severity. And then very slowly, over the course of days, it will resolve and go back to normal. If you wait until the swelling is at its most severe point, like with this red line, the swelling does resolve faster, but you can still see that there is quite a lot of severe swelling present, and it takes quite a long time, several hours or still days, before that swelling will settle. In contrast, if you treated it at the beginning, which is this green point here, the swelling can settle down much faster, and you'll see much less severe swelling. And that's why it's very important that you have good, easy access to the on-demand medications. If it's in your home and you're at work, that might not allow you to use it very quickly. And so in general, we want you to be able to access this as soon as swelling develops. So now I want to switch gears a little bit and talk about how we prevent attacks. Prevention of attacks is very important because we know that even having a single attack in a year significantly impairs a patient's quality of life. And it's because that attack itself can be very disruptive, and also because of concern and fear for the next attack, since they come unpredictably. And this is the concept behind prevention, and we call that long-term prophylaxis. There are 4 treatment options for long-term prophylaxis. The one in the top left, Cinryze, is no longer readily available in Canada, though it is Health Canada approved. And that's an IV form of C1 inhibitor protein that's collected from blood donors. And it would be given twice a week with the idea that if you replace the C1 inhibitor or that missing break I showed in the pathway, you can help prevent attacks on an ongoing basis. There is also a injection that you can get for the fatty tissue in the tummy, for instance, that also has C1 inhibitor, and that is called Haegarda, and that's also given twice a week, and can help prevent attacks. And then we have a different strategy, which is blocking plasma kallikrein using the drug itself. And I'll show you that in the pathway shortly. But we have two drugs available in Canada that do that. One is called lanadelumab, and the brand name is called Takhzyro. And this medicine is injected into the tummy every 2 weeks, although the interval can be extended in some patients. Um, and there is also an oral drug that also blocks plasma kallikrein, and the brand name is Orladeyo, and the drug name is berotralstat. And that's a pill that you take every day with food. If we look back at our pathway here, you can see that in the top right-hand corner, we have our ability to replace the missing break by giving back the C1 inhibitor protein. And we have the ability to block the scissors directly using berotralstat or lanadelumab, which directly inhibit the plasma kallikrein protein. And in this way, you can conceptualize this pathway as representing improving the balance. So in individuals who don't have hereditary angioedema, they make C1 inhibitor and plasma kallikrein, and they're in harmony and balance together. If you have hereditary angioedema, you don't make good C1 inhibitor protein, but you do make the plasma kallikrein, and we have this imbalance. So you can either get more C1 inhibitor by using things like C1 inhibitor IV, like Cinryze, or subcutaneously, like Haegarda, or you can bring down the plasma kallikrein using lanadelumab and berotralstat to replace that balance. But we need these two to be in harmony to prevent the episodes of swelling. So I want to now chat a little bit about treatments that are coming soon or maybe on the horizon. And we'll start off talking about on-demand treatments. Um, there is a new medicine called sebetralstat, and this is an oral medicine that blocks plasma kallikrein. And it is rapidly absorbed so that you can use it to treat an acute episode of swelling. And the concept of this is twofold. One, it is much more convenient for a patient to use and carry around a tablet than it might be for an injection. And two, I showed that graph earlier about why we want patients to treat earlier. And if there is such a low barrier to treatment with just taking a quick pill that you could keep in your pocket, you could take that treatment very rapidly and settle attacks much more easily. And so that's the idea for trying to get these oral on-demand treatments to our patients. And the phase 3 trial, which is what we would call the pivotal or main clinical trial used to test how effective and safe a drug is, actually was reported earlier this year. And it was a very successful trial. It showed that the sebetralstat medicine was used very rapidly by patients in the study. And compared to the placebo group or the patients who didn't get the active treatment, it settled those attacks down much faster. And so this is a promising new drug that we hope will come to Canada in the next 1 to 2 years. That same concept of oral on-demand treatment is also encapsulated with another drug that's in development, and this one is called deucrictibant. And deucrictibant works a little bit differently. It is more similar to icatibant or Firazyr in that it directly blocks the activity of the bradykinin. So if we go back to our pathway here, you can see that sebetralstat will rapidly block the scissors, and the deucrictibant will rapidly block our triangular bradykinin here. Deucrictibant is also rapidly absorbed, and that's why it can be used for acute treatment, but it's still undergoing testing. And the main pivotal or phase 3 trial is actually active right now. And we hope to get encouraging results soon. Next, I want to chat a little bit about new preventative or prophylactic treatments. We anticipate the next new medicine to come to Canada will be a drug called garadacimab. And this actually is targeting a new protein that hasn't been targeted before, and that is factor 12A. So if we go back to our pathway here, you can see where it says factor 12 that activates plasma kallikrein. So this is where garadacimab is acting. It's given subcutaneously at home. It will be given once per month. And the phase 3 study came out early this year, and it showed that it was quite effective, reducing attacks by 80 to 90% and making attacks shorter and less severe. And then we have some additional drugs in the pipeline that are a little bit further away, but we still are hoping will come in the next couple of years or few years. One is called donidalorsen, and this is different technology in that it blocks plasma kallikrein, the scissors, but it does so not by blocking the protein, but by actually blocking the template for the protein. And the template for the protein is called messenger RNA or mRNA. And so when the liver makes this plasma kallikrein, first it decodes the DNA to make this template, the mRNA, and then it uses that template to make the protein. And so the concept behind this drug is to actually inhibit the mRNA rather than the protein. And it also was found in a study published earlier this year that was, again, one of these phase 3 pivotal studies to be highly effective, reducing attacks by 80 to 90%. There's also a drug called navenibart, previously called STAR 0215. And this is a biologic or monoclonal antibody similar to lanadelumab in that it targets plasma kallikrein. But the innovation here is that the antibody has been modified with the intention of less frequent dosing. So it's anticipated to be given maybe every 3 months or every 6 months. And the study results for the phase 1b/2, so an earlier phase study, are expected to come soon. But this might also be an encouraging treatment option in the future. I also wanted to touch on gene therapy because I've been getting many patients asking me about this technology. And it's exciting that this is expected to come to patients, at least in the form of a clinical trial in the near future. There is an investigational drug called NTLA-2002, and the concept here is to target now the DNA of kallikrein. So to recap, medicines like berotralstat and lanadelumab that we have available today target the kallikrein protein. Donidalorsen that I mentioned on the last slide targets the messenger RNA, and that's the template for the protein. Now we're actually targeting the DNA, so that's the template for the template, so to speak. And you may have heard about CRISPR-Cas9 gene editing technology. And the idea is actually to edit this gene so that the plasma kallikrein template can no longer be made. And that means then the protein won't be made either, or at least it'll be made in reduced quantities. The way this is envisioned is it would be given as an IV infusion, and it would be a single treatment. And the DNA in the liver would be edited, and it would prevent the DNA from many of those cells in the liver from making this plasma kallikrein protein, so that the amount of plasma kallikrein is significantly reduced, with the hope that that will provide ongoing protection against angioedema attacks, even though you've only received one dose of medicine. Actually, I was interested in adding this because the Results of the phase 2 trial were released just earlier today, October 24th. It showed that after a single dose of treatment, when patients were followed for roughly 4 months, so it was 16 weeks in the study, compared to placebo, there was a significant reduction in the attack rate. And so you can round it for this group that received 50 milligrams of the drug. There were 11 patients. About approximately an 80% reduction was seen in the frequency of attacks compared to placebo. And again, that was only with a single dose of treatment. And so these are very exciting results, and we anticipate that this will move on to a phase 3 clinical study to fully evaluate the effectiveness and the safety of this approach. Now, in terms of innovations for diagnosis as opposed to treatment, more and more frequently, we are doing genetic testing, which we haven't been doing as much in the past for hereditary angioedema type 1 and type 2. Because it's a genetic disease, it is amenable to diagnosis by genetic testing. And now that the cost of genetic testing has come down, it's made this diagnostic approach much more available. And now in a number of provinces in Canada, we do this on a fairly routine basis. It's not required, so the standard measurement of the C1 inhibitor protein, which is what we've been using to diagnose this condition for many years, still is a good approach. But in certain groups of patients, like women who are pregnant, very young children, or women who are expecting and want to know if their child is going to inherit this condition, genetic testing can be a valuable tool. And we also use it in the cases where the standard form of testing provides us with results that are difficult to interpret, or what we would call indeterminate. This can sort of be the arbiter and decide if the test is positive or negative. Next, I'd like to chat about a different group of patients with hereditary angioedema. And in the past, we called these patients hereditary angioedema type 3 because the other groups were 1 and 2. Now it's called hereditary angioedema with normal C1 inhibitor. And in these groups of patients, they have similar episodes of swelling, like the pictures I showed earlier in the presentation. But when we do the measurement of C1 inhibitor, it's entirely normal. And so the mechanism of why they get swelling is different. There are some genetic causes identified that causes this problem. And this is a very active area of research. And so I've listed 6 genes here, but already there in recent publications, a couple of more genes have been identified. Mutations in factor 12, which I did mention in the pathway that we discussed earlier, are one of the most commonly identified genetic causes of hereditary angioedema with normal C1 inhibitor. And some of these are very rare, with only 1 or 2 families described. But certainly, genetic testing is very important in this condition, because it's one of the ways where we can have a positive finding and really nail down a diagnosis for a family. Unfortunately, we know now that when we test wide groups of these patients, in most we will not find a genetic diagnosis, and so in the majority still are considered hereditary angioedema with normal C1 inhibitor, and there is probably a genetic basis, but we just haven't been smart enough as a community to make those discoveries, though we hope to do so in the future. When I discuss genetic testing with patients and family members, a frequent question that comes up is, will this affect my insurance or my ability to access medicines? And there was a Genetic Non-Discrimination Act passed by the federal government of Canada in 2017, and it prohibits any person from requiring a genetic test or disclosing previous genetic testing. And so no one can compel you to disclose genetic testing, whether that is another physician or an insurance company, etc. And so I explain to my patients that we are able to make that disclosure with their permission if we think it's going to help their care. If we think, for instance, it might help them access medicines they can't otherwise access, but we are under no obligation to disclose that information. So they should not fear that this will be used against them. Now, individuals do move, and so this, of course, is limited to Canada. And if a person moved from Canada to a different country, it's possible the same laws would not apply. So that is something to keep in mind. But certainly within Canada, we do a lot of genetic testing, and fortunately, we have this protection in place. Now, in terms of service care delivery, that's another opportunity for us to innovate and provide better care for patients with hereditary angioedema. There is actually a network called the Angioedema Centers of Reference and Excellence, or ACARE. And this network was created by physicians around the world with the intention of creating a foundation for how clinics could deliver the best quality care available worldwide to HAE patients. And so relatively recently, Edmonton, where I work, became an accredited ACARE center. And these are pictures of my colleagues that help our HAE patients enormously, caring for them on a day-to-day basis. And the innovation and the concept behind ACARE is looking at the patient holistically. And I think in the past, in the medical profession, we're guilty of focusing too much on just very specific, easily quantifiable aspects. How many attacks did you have? How many doses of treatment did you use? But hereditary angioedema affects patients broadly, not just within a specific episode. For instance, some patients might not seek job opportunities or may not pursue certain recreational activities or restrict their children from engaging in certain things because of worries around having an attack and what to do. So there is a broader influence on quality of life. And by having a comprehensive approach where there's a physician, a nurse, we have a social worker, as well as admin staff, we come together and we all provide perspectives. And our hope is that throughout Canada, we will be able to deliver care for HAE patients using this type of comprehensive model. And this is an image of what this comprehensive care model looks like. The way we implemented it is, of course, the patient who is in charge of the care is in the middle. And each one of us care providers is one spoke from the patient, doing their specific duty to help the patient in any way they can. And so, as I mentioned, we have a physician, nurse, and social worker. And then we also incorporated dental care. And the reason for that, of course, is because some patients have difficulty accessing dental care since they need pre-treatment in advance, in many cases, to prevent swelling, what we call short-term prophylaxis. So that concludes my presentation. I'd like to thank Charles for inviting me to speak about hereditary angioedema and the exciting new developments in the field. And I'm happy to answer any questions.
Thank you very much, Adil. You shine lights on what's going on and what's coming up. I think we have a very bright future in front of us. The science is moving very, very fast, and these are very good news coming up. We just hope that everybody's going to be having access to all of these treatments for each single province, and also that every type of HAE is included, not only focus on 1 and 2, but also, as I mentioned earlier in the Congress, that here in Quebec, the population of normal C1 is more than 38%, mostly near 41%. That is pretty high. So that's why we're investing a lot of time and money to make sure that we help whoever wants to put time and research to make sure that we can get some conclusive results on getting some sort of diagnose for normal C1, so that at the end of the day, everybody's equal, everybody has access to all these great coming up treatment. And thank you very much. Well done. And thank you for being part of that.
It's my pleasure. Thank you very much for having me.